Acoustic Neuroma and Glomus tympanicum. Dr. Vishal Sharma. Acoustic Neuroma. Introduction aka vestibular schwannoma, neurolymphoma. Benign, encapsulated, slow-growing tumor arising from Schwann cells of superior vestibular division of eighth nerve within internal auditory canal. Rarely from inferior vestibular or cochlear division. Tumor growth, tumor expansion within internal auditory canal. Causes widening and erosion of IAC. Appears in cerebellopontine angle, greater than 2.5 cm. Involves 5th, 7th, 9th, 10th, 11th cranial nerves. Displacement of brainstem and cerebellum. Raised intracranial pressure. Involvement of 6th and 3rd cranial nerves. Classification as per size. 1. Intracanalicular, confined to IAC. 2. Small, up to 1.5 cm. 3. Medium, 1.5 to 4 cm. 4. Large, over 4 cm, tumor size. Intracanalicular. Small. Medium. Large. Epidemiology: 10% of all brain tumors. 80% of all cerebellopontine angle tumors. Age: 40 to 60 years. Male, female equals 3 to 2. Unilateral, 90%, bilateral, 10%. Bilateral equals von Recklinghausen's. Neurofibromatosis. Clinical staging: otological stage, due to pressure on eighth nerve. Other cranial nerve involvement. Brainstem plus cerebellar involvement. Raised intracranial tension. Terminal stage, failure of vital centers of brainstem and cerebellar tonsil herniation, otological symptoms and signs. Progressive, unilateral sensory neural deafness. Poor speech discrimination, disproportionate. Tinnitus. Mild vertigo. Nystagmus. Vestibular symptoms appear late due to slow tumor growth and vestibular compensation. Other cranial nerve palsy. Trigeminal, first nerve to be involved. Loss of corneal reflex. Pain, numbness and paresthesia of the face. Facial. Hypoesthesia of posterior external auditory canal wall, Hitzelsberger's sign. Facial weakness, loss of taste, and lacrimation. Other cranial nerve palsy. Glossopharyngeal, vagus and accessory spinal. Dysphagia. Hoarseness. Nasal regurgitation. Decreased gag reflex. Abducent and oculomotor. Diplopia. Brainstem involvement. Ataxia, weakness of arms and legs tendon. Reflexes exaggerated. Cerebellar involvement. Ataxic gait, fall on affected side, intention. Tremors past pointing to stylochokinesia. Increased intracranial tension. Headache, projectile vomiting, blurred vision. Papilledema, abducent nerve palsy, first symptoms: hearing loss, 80 to 100%, vertigo, 10 to 50%. Tinnitus, 5 to 10%. Earache, 5%. Sudden hearing loss, 5%. Facial paralysis, 1 to 2%. Investigations: pure tone audiometry, high frequency SNHL. Speech audiometry, ST scores less than 30%. Tone decay test, positive. Stapedial reflex, decay greater than 50% in 10 seconds. BERA, wave V greater than 4.2 ms, interwave V greater than 0.2 ms. Caloric test, IL canal paresis or no response. CT scan with contrast, for tumor greater than half a centimeter. MRI with gadolinium contrast, best. Pure tone audiogram. Speech audiometry. Rollover phenomenon. Galorogram. Brainstem evoked response audiometry, BERA. Contrast CT scan. Contrast MRI, neuroanatomy. Contrast MRI, intracanalicular. Contrast MRI, small. Contrast MRI, medium. Contrast MRI, large. Bilateral tumor, small. Bilateral tumor, large. Treatment 1. Observation 2. Microsurgical removal, partial or total. Translabyrinthine approach. Retrosigmoid or suboccipital approach. Middle cranial fossa approach. Combined approach. 3. Proton stereotactic radiotherapy. 4. Brainstem implant, after BL tumor excision. Observation indications. Age greater than 60 years with small tumor and no symptoms. Tumor in only hearing, better hearing ear. Serial MRI used to follow growth pattern. Treatment recommended if hearing is lost or tumor size becomes life-threatening. House Ear Institute 1977. Incisions. Middle cranial fossa. Retrosigmoid. Translabyrinthine. Retrosigmoid approach. Suboccipital approach. Translabyrinthine approach. Middle cranial fossa approach. Surgical approach protocol. 1. Intracanalicular, middle cranial fossa approach. 2. Small, less than 1.5 cm, retrosigmoid approach. 3. Medium, 1.5 to 4 cm. A. Hearing fine, retrosigmoid approach. B. Hearing bad, translabyrinthine approach. 4. Large, greater than 4 cm, translabyrinthine, combined. Pure tone average less than 30 decibels, ST score greater than 70%. Intraoperative photograph. Proton stereotactic radiotherapy. Single high dose of radiation delivered on a small area to arrest or kill tumor cells. Minimal injury to surrounding nerves and brain tissue. Gamma knife, radioactive cobalt LINAC X knife, linear accelerator cyber knife, robotic radiosurgery system. Indication: 1. Surgery refused, contraindicated. 2. Postoperative residual tumor, treatment planning. Treatment planning. PSRT in progress. Pre and post treatment. Glomus tumors. Introduction synonym: chemodectoma non-gromaphin paraganglioma. Commonest benign tumor of middle ear. Derived from glomus bodies distributed along parasympathetic nerves of head and neck. Consists of paraganglionic cells derived from embryonic neuroepithelium. Introduction: histologically benign but locally invasive, highly vascular, non-encapsulated, slow-growing tumors. 10% tumors, familial. 10% tumors, multicentric. 10% tumors, functional, secrete catecholamines. 4% tumors, metastatic. Histopathology. Typical cellular groups: zelbilin, surrounded by a capillary network. Types: glomus jugulare rises along jugular bulb and superior vagal. Ganglion, near floor of middle ear. Glomus tympanicum, arises along tympanic plexus on promontory. Formed by tympanic branch of glossopharyngeal nerve, near medial wall of middle ear. Spread. Common symptoms seen in 40 to 60 years female, male equals 5 to 1. UL deafness, progressive, conductive. Pulsatal tinnitus, synchronous with pulse. Decreases on carotid occlusion. Blood-stained otria. Earache and vertigo, rare. Signs: rising sun sign, red reflex on otoscopy. Brown's pulsation sign on signalization, positive pressure tumor engorges, tumor blanches, pressure release, tumor engorges. Oral mass, bleeds on touch. Systolic brute, overmastoid on auscultation. Neurological, 9th, 10th, 11th cranial nerve palsy, rising sun sign. Blood-stained otria. Bleeding polyp. Investigations: 1. Pure tone audiometry, conductive deafness. 2. High-resolution CT scan with contrast. Erosion of carotid-jugular spine, Phelps sign. 3. Magnetic resonance imaging with gadolinium contrast, for soft tissue and intracranial extension. 4. MR angiography, non-invasive, for invasion of internal jugular vein and internal carotid compression. Investigations: 5. Digital subtraction angiography. 6. 4. Vessel angiography. Tumor blush. Feeding arteries. Contralateral circulation. Embolization, within 48 hours of surgery. Other carotid body tumors. Investigations: 7. 24-hour urine vanillomandelic acid level, greater than 7 mg. Catecholamine secreting tumor. Initial hypertension during surgery followed by hypotension. 8. Careful biopsy of mass in extension auditory canal, rule out malignancy. Ear packing done for profuse bleeding. CT scan plain. Glomus jugulare. Plain and contrast CT scan. MRI with contrast. 4. Vessel angiography. Digital subtraction angiography. Pre and post embolization. Magnetic resonance angiography. Fish staging: Stage A, tumor limited to middle ear cleft. Stage B, tympanomastoid tumor sparing. Infralabyrinthine bone. Stage C, tympanomastoid tumor eroding. Stage D1, intracranial extension less than 2 cm. Stage D2, intracranial extension greater than 2 cm. Surgical treatment: anterior tympanotomy, small stage A. Extended facial recess approach, large stage A. Modified radical mastoidectomy, small stage B. Combined modified radical mastoidectomy plus Fish's infratemporal fossa approach. Large stage B, stage C. Subtotal temporal bone resection, stage D1. Anterior tympanotomy. Infratemporal fossa approach. Facial nerve decompression. Facial nerve rerouting. Tumor excised. Other treatments: tele, radiotherapy, 4,000 to 5,000 rads, or stereotactic radiotherapy. Inoperable, residual or recurrent tumors. PT unfit for surgery or refuses surgery. Observation, PT greater than 70 years with minimal symptoms. Embolization. Before surgery, reduces vascularity. After RD, for residual or recurrent tumor.